We'll take turns introducing folks. I'll introduce our first speaker, Vic Velanovich, ex of Detroit and now in sunnier climes, recently of Florida. And Vic, as you all know, is a great contributor to evidence-based medicine, and particularly in the realm of foregut disease, and is going to talk to us about what's going on with anti-reflux surgery referrals.
Well, thank you, Lee, and members and guests, good morning. I have no disclosures. So this is what I was charged with addressing. I'm going to talk about and document the changes in the number of anti-reflux operations which are currently being done in the United States, discuss the potential causes of this, and also discuss intervention to achieve the right level of referrals as opposed to too many or too few. I think I'm going to have to duck often because I'm going to say things that may ruffle feathers, and so I've come up here prepared to suffer some slings and arrows. So this is the changing pattern, and this was first discussed by Sam Finlayson when Sages was in Dallas, when he presented these data, which showed that from 1990 through 1997 there was a rapid increase in the number of anti-reflux operations done per 10,000 people here, or 100,000 people, and it was all due to an increase in the laparoscopic component of that. The open component did decrease, but not to the extent that the laparoscopic component. Okay, I'm still pointing with the pointer, though. Okay, thank you, though. Second, Finks and Berkmeyer, also at the SAGES meeting, showed that, in fact, the number of anti-reflux procedures started peaking around the year 2000 and then started declining. And this was the first time that the concept of the rise and fall of the reflux procedure came up. The most recent data is from Wang et al., which was published in Diseases of the Esophagus just, I think, December of 2010. And they once again confirmed that 2000 was the peak, and we see a continued decline, now maybe stabilization at the 1995 level. Around the same time, and I want you to remember this because we'll come back to this later, there's been a rapid increase in laparoscopic gastric bypass. So it's clear that 2000 was the peak of the number of anti-reflux operations, and these now have started to decline, and hopefully they have stabilized. So I think a fundamental question that we need to ask ourselves, were too many being done then in 2000, or are too few being done now? Now I have my biases. I'm sure other people have theirs. The second question, if too few are being done, what had changed during that time? And can we as surgeons bend the curve to take a healthcare reform phrase in the other direction? So, has medications changed? Well, the answer to that is yes. This is that graph I showed you before from Finks, which showed the peak being in 2000, started dropping off. And here has been the years of FDA approval of a variety of medications, where cimetidine was 1997, and then Nexium was down here in 2001. There also has been trials showing that really there has been not a great deal of difference between laparoscopic operations and medical therapy. This is the Lotus Trial, which compared a laparoscopic anti-reflux operation to medical therapy. And this is a curve of percentage of patients in remission, and they are pretty close to the same. And the conclusion was medicine is just as good as surgery, and not that surgery is as good as medicine off of medication. It was spun as, why do an operation when the medicine works as well? There also has been studies, again, in the GI literature showing that the, quote, natural history, unquote, of reflux is not that bad. If you stay on your PPIs and stay off of NSAIDs, you do not get, supposedly, you do not get any of the poor outcomes of reflux. You don't get much by way of esophagitis, you don't get much by way of stricture. However, what they don't tell you is how well the symptoms were controlled in these studies. And if you think about it, that's why patients come to their doctor for reflux, is to control their symptoms. But I think this was the seminal event that started the decline. This article from Speckler and JAMA looking at the long-term outcomes of medical and surgical therapy from the VA trial. And this was published in 2001, and this showed a very surprising difference in survival between patients who had medical therapy versus surgical therapy, which as yet is still unexplained. And then this rather innocuous statement in the discussion of that overall 92% of patients of the medical group are still on medication, and 62% of patients on the surgical group went back to medication. They don't say why they went back on medication. They don't say whether the reflux has recurred, and they don't say whether in fact going back on medication helped them. All they just said is that they went back on medication. And this continues. This study in 2006, again by gastroenterologists, and I want you to pay attention to the results and to the wording. Overall, 90% of patients were satisfied with their operation. 80% were willing to undergo surgery again. 2/3 had a decrease in the severity of their symptoms. 80% were back on medications, and look at the conclusion. Most patients continue to use anti-reflux medications, most patients continue to use anti-reflux medications, including those after laparoscopic Nissen fundoplication, despite high satisfaction with surgery. The conclusion isn't patients are really satisfied with an operation. The conclusion isn't their severity of symptoms were decreased. The conclusion is they are back on medication, and therefore the operation failed. We bear a little bit of responsibility for this notion as well. This is a follow-up study comparing laparoscopic versus conventional Nissen fundoplication, which was published in the Annals of Surgery, one of our high-impact journals. Very careful study, nicely done, showing that after 10 years, 20 to 25% of patients in either group were back on their medications, and this slowly increased over time. I've had patients, as I'm sure many of you had, that come to me for an evaluation for Nissen fundoplication who were told by their gastroenterologist that the operation is pretty good, but it only lasts 10 years. And this is the data that they're looking at. Not that 75 to 80% do well, but that some patients do have recurrence of their symptoms, and therefore the operation fails. However, we do have to acknowledge that there are serious complications with a Nissen. This includes an overall complication rate of 8%, and some are serious. Splenectomy, transfusion, being on TPN, and the mortality rate increased from 0.26% to 0.54% from 2000 to 2006. So, you're a primary doctor or a gastroenterologist, and you have a patient with reflux, and the medication works just, in your opinion, the medication works just as well as the operation. The operation can have some serious complications and side effects, and you know what? It doesn't last very long either. So that's the attitude out there within the medical community, and these are the data that have driven that. Now, interestingly, I showed you this earlier, where the fall in number of Nissen fundoplications does curiously correspond to the rise in gastric bypass. Now, many of our reflux patients are obese, and how many of them are getting gastric bypass instead of a Nissen is hard to know. I suspect it's not that great, although there might be some drop-off in the rate of Nissen fundoplications because of gastric bypass. Okay, so what can we do about this? Well, I'm not going to talk about these things specifically. I think the other speakers are going to, but we need to select the patients appropriately. There are many patients who probably got a Nissen that shouldn't got a Nissen, and therefore they had poor outcomes. And the operation was blamed for their outcome when in fact It was poor patient selection. We need to do the operation well. I am sure many of us here in this audience have had the misfortune of taking back somebody else's Nissen fundoplication to redo because it was done poorly. We need to keep track of our outcomes, not the outcomes of the group as a whole, but your individual outcomes. And I'll make a little plug for that later on we're going to have a panel session about keeping track of your own outcomes later today. We need to take care of our complications and side effects. I've gotten more than one call from an irritated gastroenterologist where a Nissen was done, and when the patient had some problem like dysphagia or bloating, was sent back to the gastroenterologist. I don't like taking care of my own complications, let alone somebody else's, so if you're sending a patient with problems back to the gastroenterologist, you're not probably going to get more referrals. Consider referral to high volume center. I'm not going to touch on this, but it's also true that those complication rates that I showed you earlier, splenectomy, TPN, transfusions, are lower at high volume centers than low volume centers. And I think this is the big thing. We need to educate referring physicians and patients as to not only our outcomes, but the adverse events of proton pump inhibitors, because these things aren't like taking a one-a-day vitamin. So, laparoscopic Nissen fundoplication generally gives superior symptomatic outcomes to medication. Here's a randomized trial that was published in a high-impact medical journal recently, showing that when you randomize from surgery to medication using well-validated quality-of-life instruments, the symptomatic improvement is better with surgery than with medication. Now, this is an interesting group over here. What's a preference participation? These were patients who were evaluated for randomization but refused randomization because they wanted to go either, they definitely wanted to have surgery, or they definitely wanted to stay on medication. And it's interesting that the symptoms were pretty similar in that group, and I think that probably has a lot to do with patient preferences and patient expectations. Now, the natural assumption among gastroenterologists and primary care physicians is that if a patient went back on medication, the operation failed. Now, these are, I think, two landmark studies, one by Dr. Demeester's group at USC and the other by Dr. Swanstrom's group in Oregon, showing that although patients were on medication, less than a quarter actually had abnormal pH studies documenting pathologic reflux. And that was true both in California and also in Oregon, where less than 30% had abnormal pH. So what that means is here were patients who not just were placed on medication inappropriately. In my opinion, they were done a disservice because the real cause of their symptoms was never investigated and never diagnosed and never adequately treated. They just were placed on PPIs. So this is a study that we did a while back where we did a case-controlled study looking at patients who were on medical therapy versus those that had a fundoplication done, and we matched them for all factors, including the month of treatment. And we find that with a follow-up of nearly 30 months, that the medication, patient months of medication were 10 times, or I'm sorry, not 10 times, 100 times higher in the medical group compared to the surgical group. And if you look at the additional procedures that were done after starting the study, there were much more upper endoscopies and other additional procedures done in the medical arm versus the surgical arm. Of course, I had some bad complications here, and I'll acknowledge that. But still, overall, more people had more procedures in the medication arm than in the surgery arm. Now, this is the thing that I find most telling. Of the patients who had symptoms, only 12.5%, two patients, had a workup prior to being placed on medication to make sure that, in fact, they had pathologic reflux, and both of those patients were mine. They came back and complained to me, and I did an evaluation and would acknowledge that the operation failed. None of the patients who were placed on medication by anybody else actually had an evaluation. And this what I think is most interesting, and this you won't find any, at least I don't think anywhere else, is that only 25% of patients placed on medication after a Nissen that, quote, failed, actually had symptomatic improvement. So what that means is that, in fact, they had some other cause of their symptoms that was yet undiagnosed, but it was blamed on the operation. PPIs have problems too. And we're going to learn more and more about this. Nearly twice the incidence of C. difficile-associated diarrhea, nearly twice the incidence of community-acquired pneumonia, increase in hip fracture, and increase in cardiovascular death. Death with Plavix, not just cardiovascular event. So I'm an old Army guy, so I like battle plans, and I think this is what our battle plans should be. First, you gotta make sure you do a good job. Everything is predicated on that. Prove you do a good job. Keep track of your results. Educate your referring physicians, including primary care as well as gastroenterologists, and please be prepared to take care of your poor outcomes because that gives a bad name to all of us. Thank you. So we're gonna talk all at the end?
Yeah, we'll take questions now. Thank you very much, Vic. That was great. Questions from the audience for Dr. Velanovich? I might ask you. I'll ask you.
Everybody.
Yeah, ask you a question about the Wang data and the mortality rates going up. What do you think is going on with that?
Yeah.
Is it a case mix?
Yeah, no, I think it's definitely a case mix. I think what's happening is that older patients with bigger hernias and with more comorbidities are being operated on, and I think if you change that and actually did true risk adjustment, like in the nest whip type of methodology, you probably would see that go away. But having said that, that's not how it gets interpreted.
Yeah, it's a lethal surgery.
Yeah.
Dr. Velanovich, I had a question for you regarding referral patterns. And you've contributed a lot to, the quality of life questionnaires, understanding the atypical symptomatology and its role. Do you see pulmonologists, ENTs being more part of the referral than there used to be because of a better understanding?
Yes. In my practice, the typical symptoms have gone down, and either the large hiatal hernias and paraesophageals have gone up, and then I get actually a lot more referrals from ENT doctors because of reflux-related laryngitis or other types of symptoms. I do think that there is a change in referral pattern as well from that standpoint. But I couldn't find hard data to show that.
Might add one more thing to your list of things surgeons can do, and we've been lucky in Portland to not see a decrease in volume, but we run our own motility lab and do all of our own testing, all of our own endoscopy, and so we kind of offer the service from start to beginning, and I think that's something surgeons should consider if you have a special interest in this.
Yeah, that's an excellent point. Excellent point.
Great. Thank you very much, Vic.
Thank you.